recession and cutbacks in coverage that have led to really increases in the number of uninsured patients, and as a result, sharp increases in the uncompensated care that hospitals are facing. And this has, of course, been at a time when hospitals are also struggling to figure out how are they going to make the changes necessary to implement everything that's coming up in 2014. So certainly this is an issue that has been a particular challenge here in Goodyear. We've also talked about the fact that hospitals really are a mainstay of economic stability for an area. And so while obviously patients and patient care is the most important thing that we always talk about, it's also very much important to the city's economy. And that's been something that the cities who have looked at this ordinance around Arizona have really been thinking about as they've looked at these programs. So now we get into the meat of it. I'm going to start by reviewing the authorities under Arizona law and then also under federal law that make this opportunity possible. And again, this is the moment where you should feel free and start asking questions if any of this sounds very confusing or foreign. So Arizona has actually explicitly given local governments the ability to directly support payments to hospitals in their communities. And that's by providing funding for Medicaid, or in this case, access payments to those hospitals. And just a little familiarity with Medicaid. So Medicaid is a jointly state and federally financed program. And so federal law permits the state to either provide the state money itself, or it can rely on its local government or local public entities to provide their share of the payments, and then the federal government matches that money. And so Arizona chose to explicitly allow this in the legislation. And then since then, the state has actually been using this in a variety of programs, not just the access to care ordinance that we've seen in Phoenix, but for a variety of payments, graduate medical education, disproportionate share hospital payments. There are a variety of Medicaid payments that have been financed either through local governments, local hospital authorities, things like that around the state. So this is actually not a new concept in terms of having local governments finance the share of access payments for their providers. So that is the Arizona authority, and I'll move on. Oh,
We have a question here.
Yes.
Just
Joe?
high level, you had mentioned about the bad debt write-off and how this is going to help offset some of those write-offs. Do you know, and again, we're maybe not expect you to know this, but the percentage of the bad debt you have right now that's written off, and as a result, if this goes into place, how much will that reduce that percentage?
I would just mention that over 15% of our patients coming through our emergency department are uninsured.
What percentage? You said?
15, so over
15,
9,000 patients this last year.
So as a result, if this gets implemented, out of that 15%, I assume some of them won't be subject to this ordinance. What percent of those 15% do you think you get your money back on?
So perhaps I can answer it a little
Okay.
bit differently, and if this doesn't answer your question, then we can follow up more. The way this ordinance actually works is that, or the way that the program as an entirety works, is that there's a set way that you look at a hospital's uncompensated costs for serving Medicaid and uninsured patients, and that's going to be what we call this uncompensated care cost figure on which the payments can be based. And then we're looking at a portion of those funds, not 100%, but around like 90% of those funds. And the way that uncompensated care is defined is something that Access and the federal government, the Centers for Medicare and Medicaid Services, have set out and approved in detail for these purposes and for other purposes under their access waiver, they call it, the documents implementing it. So what we're trying to do is take of those defined costs and try to cover about 90% of those. So that's not in terms of patients, but that gives you a sense of the costs that will be covered.
Yeah, I'm just trying to get a feeling if 15%, I'm just throwing out numbers, if 15% of your total dollars are uncollectible, and as a result of this, that 15% drops to 10%, then that's a significant, as far as shoring up your financials on the hospital. That's what I'm just trying to get a feel in my brain, how that's going to work, you know, and that's what I was kind of getting from there on how well that, or how much that's going to actually reduce your uncollectibles to put your financial condition a little on sure ground than continue to write off Does that make sense?
It does. And just broadly, I would tell you this, what you're going through tonight in this ordinance has significant impact to our organization, especially tied to the calculations that we receive from the government in that uncompensated care.
So 90% is, this would address 90% of that uncompensated care within those parameters that you were talking about?
That's sort of a goal. I mean, these are estimates, and then the way things work out is slightly more complicated because there are limits and things. But the idea is that it's not 100%. Everyone would love it to be 100%. It's not going to be 100%, but it's going to be a significant portion.
Sherilyn?
Thank you.
You're welcome.
I guess I misunderstood. I thought that would be like for the last quarter. I mean, is it ongoing and there's a chance that they may allow some of the back bills in 13?
Yes. You know, I would be happy to answer that. I think there's a slide that would help give that
Okay.
more context, if that's all right. And I will make sure to come back to your question. I don't want to miss it at all. I just think it might help to get a little bit more background on the context on that one. So we spoke a bit about, so this is the state law allowing the state to accept funds from you all and use them to fund payments for the hospitals under the Access Program. So now, the other thing.
Can we
Yes.
just clarify this?
Yes.
We have the public listening.
Yes.
And when you say the city can accept funds, we want to make sure we're not talking about that the city's taking their funds. So when you do this, you need to be sure you're specific on that, okay? Because
Absolutely.
they're going to think we're taking money out of the general fund, and so essentially they're paying for the program. So if you can
Absolutely.
make sure you're clear on that as we go along.
Yes, and I
Thank
should
you.
have corrected myself, and we will get into that, but this
Okay.
is really the provider's assessment funds.
Thank
It's a
you.
self-assessment on ourselves.
Right, thank you.
Correct.
Just needs to be said,
Well said.
okay.
Absolutely. Thank you for reminding me of that. So this is now the federal authority that exists to have these provider assessments. So when you put these two pieces together, this is sort of the building blocks for this program. So the idea of assessing providers and then using the funds that are collected as the means of paying for the state or local, the non-federal share of access payments or Medicaid payments overall is very, very common. In fact, 49 states plus DC at this point now have some form of provider assessment in place. They're more typically statewide assessments, but they can be done and are permitted to be done locally. And obviously, here, the city of Phoenix is the most relevant model for all of you. So that is an assessment that it is basically an assessment on the hospitals within the city of Phoenix, and those payments are being used. The federal government has approved it, so we have a working model out there. And in addition, not only has the city of Phoenix done it, but 4 other cities have now passed ordinances. They have not gone through the full approval process. And if Goodyear were to do this, they would sort of be part of the approval process that these cities are going through. But these 4 cities have also now passed similar assessments within their city. Any questions?
I think you're all right, go ahead.
All right. So what is our proposed solution here? Given the success of the Phoenix model and the fact that other cities are currently seeking to replicate that as well, we think there's an opportunity for Goodyear to create its own access to care program and to bring in similar significant support to the city and in particular for its hospitals. So these 2 slides are really this slide and the next will outline the components of what you would see within the ordinance itself. And again, this is modeled after Phoenix because we know there's a pathway to success. The state is familiar with it, the federal government is familiar with it, and a city has already figured out how to implement it. So we've already talked about the fact that the purpose would be really to create this new funding source for these access payments to offset uncompensated care costs for the hospitals. It would be funded by this new assessment that would be assessed only on hospitals within the Goodyear city limits. So we've talked about which hospitals that would be. In terms of setting sort of how you would define what the base rate is and what the rate would be, federal law requires that you have a uniform rate for everybody. So we have to pick a rate. Right now, we've been looking at a lot of different assessment rates and the data on that. And one that seems likely is this idea of doing an amount of money per discharge on a hospital. Other ways that it's been done, so that's the way it's done in Mesa. Other places do it on % of revenue, something like that. But these are all sort of acceptable and different kinds of base rates that have been proved in these kinds of Medicaid assessments. And then it is a short-term assessment. So the assessment would expire based on language within the ordinance itself. It would sunset on December 31st of this year. So it would be a specifically time-limited ordinance. So any?
Joe?
Yes.
I want to just make sure I understand the mechanics.
Sure.
If you charge a set amount per patient leaving, and that patient could have had a $20,000 bill, $50,000 bill, then you're going to turn and put in first of all, it's assessed on you, not the patient, so you're going to be paying it. Then you're going to ask for 2-to-1 back from the federal government. If it's based on a flat amount, how are you going to get back the amount of money that you're seeking because there's no percentage? Am I missing
Sure.
something there?
No, you're not. It's an excellent question. So the way that it's done, and actually we're working with a group of consultants who do this across the country, and actually the man who is in charge used to work for the Centers for Medicare and Medicaid Services and approved waivers, so he is extremely familiar with this process. Okay. So what we're doing is figuring out if this is an estimate of how much uncompensated care West Valley has, then how much would you need to assess per discharge in order to be able to finance those payments? So that's the way that it would work. And that's the way that it would work if you did a percentage of revenues. You would figure out what percentage would you have to impose in order to make sure that we can finance the payments.
So the amount you're going to be assessing is already based on historicals to ensure that you get the 2-to-1 to cover what you need for the outstanding.
That's the idea, exactly.
Okay. Thank you. Sherry?
Just want to be really clear. The patient doesn't pay this?
No, and not at all. And so I'll continue reading that actually. So the way that it works is that the hospital is basically, it's being assessed these funds, but they want to be assessed these funds because we know that that's going to be transferred to Access and be able to be matched, and so then you're going to receive greater payments. So in the end, there's a benefit, and so there's no reason, nor would they be able to pass the payments, the costs of the tax along in the ordinances, all of them that have been passed. There's actually been explicit language, and I have an example of the language on a slide later, but there's been explicit language. But really the point is that overall this program is a benefit, so it's not going to cause that. There's not going to be a line item saying this is an increase to your bill because we have an access to care ordinance. That is absolutely not the purpose.
And with the exception of the hospital being a taxpayer, none of your taxpayers and none of your patients have any burden of this ordinance.
Yeah, I just want to be really clear that the citizens aren't going to see a tax or anything along those lines.
If anything, this is a benefit to the city because
They may be in that case, some of them.
they could
that
be in
aren't
that
paying,
case,
that
and
can't pay.
we know the burden that uncompensated care in general places upon a system, and so this is
And then my other question is, why would it expire on December 31st, 2013? Is that because the Affordable Health Care is going to kick in hopefully then? And if that doesn't, what do we do if that's delayed in any way?
Well, so currently the way that it's been set up that way is because the access, the way the program is implemented is through a waiver. They call it a waiver. It's a document that outlines the way that your program works. And Arizona has a very special program that exists through this document. And so the amendments that have been made to that waiver will basically expire. They're being negotiated now, and then they're going to change starting January 1. And so a lot about the healthcare system is going to change January 1. And so really the intent from the beginning of this program was to fill in gaps so that there would be a bridge to whatever's happening. And if we'll see how things work out, but in terms of the statewide assessment, and you may have heard about this idea of a statewide assessment, if that goes into effect, then there won't be local assessment opportunities anymore. So it's a combination of reasons, but the ordinances so far are set to sunset December 31st, regardless of what else might happen.
Joe?
I assume, like insurance, the government has a schedule of rate at which you get reimbursed for the actions or the medical that you're doing. Is that correct?
Correct.
Okay. My question is, just I want to ensure that if you collect from the federal government, you won't be collecting from the patient.
No, yeah, and that's really, so part of the way that this works is that the costs that are used to determine how much the payments are going to be made are reported on this standard form that's used for Medicare purposes, but these cost report purposes. And so the way that things are categorized make it clear sort of what these costs are, bad debt versus charity care versus other things. So it's very clear what these costs are. And also the other thing is that they're not going to be paid for their full unreimbursed costs. So if for some reason there was someone who later came back and was able to make a payment, they're not going to have been paid for 100% of their costs. And we do that intentionally to make sure that there is not going to be any double payment issue.
Okay.
Okay, thank you.
Okay. All right, so this was really the first part of the assessment. Now the second part is what we just started to talk about. So now the city has the providers assessment funds. The city transfers those funds to the state. And that would be done through an intergovernmental agreement with Access. And this is also a process that Access is quite used to going through with providers and local entities. And I will tell you that when we did the Phoenix model, it was really a painstaking process to make sure that the state understood the position that a city was in and vice versa, and to really make sure that everyone felt comfortable with the responsibilities that the relative government agencies had. So that's sort of a model that Access has and can work off of now.
And what man-hours does that take for a city? And does that take a position? Does that mean we need to add a position, or is our departments able to take that on?
In working with the finance director, Larry Lang, we did look at that, and it's really kind of passing it through, just like our improvement district, so we collect it and we pass it through. We can choose to do it one time, or we can choose to do it 2 times within that quarter or monthly, but he did not think it would be a significant impact. And I think you might get there, there is the ability to cover our cost with an administrative fee as part of that assessment if
Sorry,
we
I
so
jumped
choose
ahead
to
of
do
you,
that.
didn't I? Sorry.
But it is, according to Larry, it's not a significant, it does require some staff time, but it's more of a
But
pass-through.
insignificant compared
And
to.
it wouldn't require additional
Okay.
staff.
Okay.
I do think one of the benefits that you have is that multiple cities have now gone through this and have done negotiations and identified the issues that are maybe more different than things that Access had encountered from, doing, having relationships with other kinds of entities. So I think you benefit from those negotiations, and hopefully that will also just transfer in terms of the man hours. But Lynette is correct that we have built in other ordinances and would anticipate that you'd want to do that here, a component for admin costs.
Great, thank you.
I have a question.
Molly?
I'd like to ask, Lynette, I'm going to run this through Brian to you, but I'm assuming that if we do this, it would be the same as if we were running a grant through our books to a nonprofit like we've done before.
So we take, organizations come to us, say they want to do a grant, but they need a city support.
They need a city
And so
support.
we run, in order for them to get the grants, we run it through us to that. That's a good
It's similar
question.
to that, the improvement districts, we collect it and then we pass it on.
Okay.
Yes, it's
Okay.
exactly
Same
like
thing.
that.
Okay, thank
That
you.
helps, doesn't it? It kind of gives you some reference. Good,
Yeah.
thank you. Joe?
So just as a follow-up, there's no liability to the city.
That is entirely what the IGAs are about, is to make sure that everyone is comfortable with that. Yeah.
We'll keep repeating that question
It's okay.
because
It's an important one.
anybody coming in and out of this presentation at home and on their computers will hear that again.
I think it's important to point out, that was one of our questions, and the reason behind the IGA with Access was what happens if we can't get the full assessment amount from the hospitals? Will the city be on the hook for any remaining balance? And within the IGA that we saw with Phoenix, they do make it clear that, and Access agreed to that the city would not be responsible for any deficit in that collection.
Not held in harm.
Not-
Okay,
yes.
all right, great.
And that is something that Access itself appreciates as a government as well. So they are very sensitive to that issue. So having transferred the funds, then, as we've talked about, the federal government matches 2-to-1 in the state of Arizona, and then that full amount will be distributed as these uncompensated care payments. So now back to the earlier question about sort of what costs might be paid for. The sub-bullet here talks about our goal being to fund uncompensated care costs basically starting for this entire last fiscal year and then also going through the end of December, sort of aligning with the end of the tax. And that is dependent on the way that CMS, the federal government agency, looks at the way these waivers can work. So, you know, if we can get everything approved and work out all the technicalities, the idea would be we can get that the full amount for the federal fiscal year and then uncompensated costs for another additional quarter. And we would just set the assessment rate so that we could make sure to collect enough to finance all of those payments. It would be a significant assistance either way, but obviously it would be preferable to get the entire year, and that's what the other 4 cities are pushing for as well, and they would be in the same boat with you on that. So another issue to note is that as a condition for federal approval in these other cities, and it started with Phoenix, and this 18% came out of sort of just happened, but basically the federal government has said you have to take a portion of the funds and use it to support coverage throughout the state. And that was because, you know, Phoenix was done, you know, a decent amount of time ago, and so there was this feeling we really need to get some sort of coverage happening earlier, and so it started, and now that's just become part of what all of the city ordinances do. So obviously, to the extent that there's coverage, it will benefit some residents of Goodyear as well, but that part of it will be spread across the state. We don't exactly know what that coverage piece would look like. That's actually something that Access is discussing directly with the federal government, and that again would be applicable to the 4 cities that have their ordinances approved but are waiting, as well as Goodyear if they were to do it. So in Phoenix, the example, basically that 18% was used to recover children who were cut from the kids' care program. And that's unlikely to be the source because there was so much support brought in for that program that there really isn't necessarily a need there. So that's something that will need to be worked out.
Any questions? Go ahead.
Okay, so what will the program do for the city? And, you know, worth emphasizing these points over and over again. Obviously, bringing significant federal funding to the city to help support uncompensated care. And, you know, we've heard from Stan the striking figures that they've been dealing with. So that would certainly be a great benefit. Access to care as well. The more that you shore up the healthcare system as a whole, then you're going to help access to care for patients. Economic development, certainly to the extent that you can stabilize and help your hospital systems. There's a benefit to the community, and they can continue projects that they've been looking at for development within the city. And then that piece that is about coverage, while it's a smaller portion, will help also provide some extra coverage to people throughout the state. So, and here we've covered, I think, almost all of these at this point, but let's talk about them again. What will Goodyear...
I'm going to stop you a moment.
Yes,
Joe
sorry.
has a question.
Another question. And hopefully not too, well, we'll put it this way. If your uncompensated care continues to drop, even after December 31st, and that percentage becomes a smaller and a smaller piece of the overall revenue, and is it too far of a stretch to say that possibly costs overall will start to come down? I'm thinking of it from a financial standpoint. I mean, if your financial condition is stronger because your uncompensated care is dropping, is it unreasonable to think that overall health care costs
I have a question to
may
add to
start to
that.
come down?
To your question, is that the norm in budgeting?
In business, if
Within a
you're...
year? Within a year?
I'm not talking about a year. I'm talking about if your financial statements are improving and you're a nonprofit company, then I would think overall your pricing should start to drop. That's my logic. Tell me if I'm
I
wrong.
could add 2 pieces, not
Yeah.
allow my team to join in as needed, but, you know, just like budgeting, you have revenues and expenses.
Correct.
So while we're talking really of shoring up revenues that weren't there, separate from the expense side of the income statement. Salaries are still going up.
Okay.
You still have, one of the things that were part of the operational impact is, we held off on benefits and 401k matching and all those other pieces because the revenues had dropped. So with those revenues coming back, that actually has an opportunity for us to make improvements tied to what we're doing with the staffing pieces, but also keep in mind in healthcare with advances in technology, it's not always that the advanced technology is at a lesser cost as well. On our capital side that we have to reinvest into our organization, you constantly are negotiating rates when vendors are trying to charge you higher and higher costs for the type of equipment that the public demands in healthcare today. So you have a mixed bag there.
Yeah, and I understand both sides of the equation on the financial statement.
course.
Obviously, though, what I'm getting at is, if it doesn't help bring it down, it should at least slow it because the one side of the equation is getting healthier. That's just where I'm coming from.
Agreed.
I guess I look at it as our emergency rooms will stay open. That's why I look at this when it was presented to me, that there'll be better care for those that are coming in the hospital that do not have the money. I think the comfort level's there. I think trust is there. The trust that they're going to get good care because the hospital is, and the people working in the hospital, they are getting paid for this patient walking in the door. This is not a freebie anymore. It is a federal program, and we're going to get citizens to say, oh, woe me, we don't need any more federal programs. But I think what we're looking at is the individuals, the people that come in the emergency room. Sherry?
When you're figuring out the percentage, there's some people that may not qualify for access. Is that figured out in that percentage that you gave us too, so that will get recouped as well, even if they wouldn't qualify for access?
I'm sorry, you're saying they wouldn't qualify because they just don't meet the
Whatever
coverage?
reason someone doesn't meet the qualifications,
Like
but
in
there's
the
still
gap between the 200% of poverty levels, et cetera, that just
yeah,
isn't
because there's some
qualifying.
people that do fall kind of without, and they still don't pay, and you guys are still out that money for the emergency room. Would that also be a reimbursement that you would kind of figure in that percentage that you're working with?
The way the rules work right now is that it's only for the uninsured and then those covered by access. So to the extent that that person had no coverage, then yes. To the extent that that person had coverage they couldn't afford and then they couldn't afford the copays or whatever, then no, and that's a significant burden.
No insurance at all.
It's no
I come in, I
insurance at
just
all.
don't have insurance for whatever reason. You figured this into your cost so you could recoup from that patient as well.
In terms of
Federal
the
government.
payments or in terms of the recoupment?
For the recoupment, that's all figured into your.
Yes, and if someone, and some people who are uninsured, there are payments that are made. It's not that every uninsured person makes no payments, and those are offset. So that is, yes, part of the calculation.
Does that help because of the people that could afford insurance and could do that? I mean, they probably come into your hospital, they've taken that chance that they're not going to get ill, so they don't have the insurance. So I suppose that's a little bit different case. I'm sorry, Lynette, you wanted to say something?
I have a gentleman here who was going to speak in a little bit, but he thought he might be able to answer some of Vice Mayor Pizzillo's questions here. This is Mr. Reginald Ballantyne. He's the Senior Corporate Officer for Vanguard Health Systems. So if you wouldn't mind,
No, please,
okay.
that's why the question's on the floor. Let's take care of it.
Thanks, Mayor.
Before you begin, Joe has something to say. Joe?
Listen, I appreciate answering the questions, but I do also agree that it's important to shore up the financial conditions of our hospitals. If they fail, we all fail.
Yes.
So with that being said, my only approach is uncompensated care is an expense as well. So that's where I was kind of leading when I was mentioning, hopefully down the road, if that decreases, we will either see a slowing or maybe mitigation of some of that increase. But go ahead.
You are absolutely correct. That is what we hope will happen, not only with this ordinance, but with the Affordable Care Act. And they're designed to do that. The thing that's pretty interesting about health care is there is only one set of providers subject to federal law that says you can come in, receive our services, even if you can't pay. And that does not apply to doctors, pharmaceutical companies, insurance companies, anybody who sells us their services. Only hospitals are subject to a law known as EMTALA. the emergency medical treatment and labor, yes. So you can walk in without funds and receive care, period. When you think that the statistic that 50% of all patients in the average American hospital are coming now through the emergency department, it kind of gives you a picture of, uh-oh, we're headed for trouble. Mm-hmm. You asked questions a while ago. Let me be pretty crisp. This will cover a portion of uncompensated care costs. It will not cover all, even if we doubled the amount that we're going to receive
And that's what
as
I
a
was
result.
trying to get at that question
Yes,
earlier.
it simply won't. The thing that is interesting also about people thinking about health care is that uncompensated care costs go away. They dissipate. They somehow vaporize. They don't. It's a hidden tax to business. And if we can mitigate that hidden tax, the cost shift, as it's called in some circles, businesses that are insuring their employees are actually paying for the people who are uninsured. It all gets paid for. Either that or you shut the hospitals down.
And that's what I was getting to, is, like, okay.
So I guess and I hope that does respond. I mean,
Yeah,
very crisply,
Yeah.
no way will this cover all the uncompensated care.
I understand it.
Fortunately, we won't have to look at reducing labor force. Fortunately, we won't have to cut nurses. Fortunately, we can go ahead with our plans for the trauma center. And let me just kind of start at the beginning. There are several of you in the room that I've had the privilege to know for decades. And you know who you are. I won't identify you because I don't want to embarrass you. But I've known you for years and years and years. When nothing existed in Goodyear with health care, and working with Brian when we were both younger, along came the Palm Valley Medical Center. That was the beginning of what is now the West Valley Hospital campus. It was at a time when people didn't really look west. Nobody really cared about setting anything up here. Hospitals certainly had an opportunity to do so, and we did, under the auspices of an organization known as PMH Health Resources. And that brought people like John Hopkins, what a great name for a doctor, by the way, but it brought groups of doctors to this campus, and eventually it unfolded into what is now the West Valley Hospital campus. So this goes back, I don't know how many years you want to identify, Brian.
In the 90s.
Yes, in the 90s. Or Sherilyn, when you sat on the board that approved this. You said it was the 90s. But this goes way back. So the organization before you tonight came to Goodyear and said, we're going to provide health care. We're going to start with outpatient care, physician services, and eventually hospital care. Now we sit at a time when there are only certain groups of people who are covered. Those eligible for Medicare, those eligible for Medicaid, those in Congress, and those in jail. So says the Supreme Court. Mm-hmm. And if you work for a business, you may or may not be covered. And everybody else, you're on your own. Tonight we're talking about everybody else on their own. And everybody else on their own, that gets cost shifted to all the other people who are paying, be it a copay or a deductible or whatever you happen to be personally paying, plus what your business is paying or whoever is taking care of you. The law that created all of this dates all the way back to 1965. So we're not talking about, oh, wow, this is something brand new and we've never heard about it before. Medicaid was created as a federal-state partnership, as you heard earlier, in 1965. And it's become very technically complicated, but in this case, thank God, it's not really that complicated. State law allows us to do it. The federal government encourages us to do it. We're going to do it, I hope. We're going to take it back to October 1st, 2012. If we don't make the train, at least we'll get a quarter. But it is my intent, based on what you do this evening, to be on a plane to Washington to meet with Cindy Mann, who is the National Director of Medicaid, saying we want to get on that train. So it's not just one quarter, it's 5 quarters. And I think we can do that. And I know that your staff has been, and I don't mean this gratuitously, fabulous. I mean, we ring up the phone and say, gee, could you get out a notice tomorrow? I mean, it almost was that way, was it not? And I was in upstate New York talking to this lady who I hadn't met and saying, no problem, right? So we're going to be 2 weeks out from that September 30th. And my request to the federal government is, look, we're 2 weeks out. The train that carries all these other cities, please let us on it. And I think we can do that.
Right.
The other points I would make is that citizens simply won't be taxed, period, end of story. Can't happen, won't happen. Why do you say that? Well, with Medicare, we get paid DRG rates. That's, I'm going to pass that on. Access, we get, depending on whether a plan or a hospital, capitation or per diem rates. Insurance companies, we negotiate, but that's tough, and those are 3, 5, 10-year contracts. None of that's going to change. There is no cost to the city, again, to be crisp, period. No cost. If you incur administrative, quote-unquote, costs, we will pay them out of this program. So no tax to the citizens. We go to our treasury. We give the money to you. You give it to the state gives it to the federal government, and we get back our money. We are a donor state. I think most of you know that Arizona is a donor state. We're simply getting our tax money back. And it will partially offset, Joe. I don't need me to be that personal with you or familiar, but we will be able to say, aha, many of the programs we want to implement, we can go ahead with. The people need to take care of our patients. We don't have to let them go. So that is kind of a little bit of what I wanted to add to this conversation. And I think tonight, if I'm not mistaken, we're asking for the okay to start the process. And that's what we're going to work our, I'm trying to think anatomically how to phrase this, but we will be working hard to make sure that this gets done in a way that I can say to Cindy Mann, look, 2 weeks, come on. Particularly given that access, the Arizona Healthcare Cost Containment System, is considered the model for Medicaid programs and is 15% more cost effective than any other program in the United States of America. And by the way, if you're interested, there was a Stanford University professor named Alan Enthoven who created the concept of managed competition. You take the best of capitalism, you have rules, you put it together. That is the access program. If we were to lay that upon America, Joe, we would take America's health care bill down 15%.
And that's what I was trying to get to.
Yeah, so
And I appreciate the background as you went all through there, because we hear all kinds of things that's going on out there. Going up, this is going down. I'm not in the business, so I don't know which direction this stuff's going into. But to me, I understand financial statements and I understand balance sheets. And I'm looking if there's a way to mitigate some of your ongoing operating expenses to a certain extent, because I know things seem to be going up, medicines, equipment, diagnostic, et cetera, that either has got to help slow things down or maybe retreat it a little bit if you can get enough of those reimbursed.
you're right with the words mitigation.
Yeah.
That's what we're doing here, is mitigation.
Yeah.
Interestingly, those that join us in providing care to patients aren't subject to EMTALA.
Yeah. I understand that.
You can't walk in, I don't think, unless I'm wrong, to Walgreens or CVS, not picking on anybody and saying, you know what, I need the medication, can't pay for it. Oh, no problem, here. You can walk into a hospital emergency department as an emergency and you're taken care of.
Right.
And the cost doesn't go away.
Right.
The cost is shifted to the rest of us. What this is going to do tonight is really, it's a wonderful opportunity. We get our tax money back to Arizona. We mitigate damage. We do it without a cost to the city. And that's why we, by the way, were the leaders with the, or Vanguard and Nebraska were the leaders with the city of Phoenix, who embraced it, and now it's taking off like wildfire. And the last comment I'll make is this is done all over the United States. I don't know who the 50th state is who doesn't participate. I just don't know. I think it's Alaska. Pardon?
It might be.
Yeah, I think it's Alaska because it's really cold or something up there, but they don't do it. But 49 states do it. Cities are now doing it. And by the way, as of January 1, 2014, we're out. And if we don't take this opportunity to do it, we lose. So you're very nice to come back from, I guess, vacations and other places, and I apologize you had to do that. By the same token, this is hugely important.
We have two questions on the table, Joel. Can I go to
Okay, yeah,
Sherry
go to Sherry.
first?
Yeah.
I do want to reiterate what you said, because I lived out here in the early 90s, and I got ill, had to be taken to a hospital in Phoenix. You know, we do need the hospitals. We need the emergency rooms for our citizens as we grow. We need the hospitals to grow with us, not to shut down. You know, and then just a couple years ago, ended up in West Valley Hospital, emergency room for a week in the hospital. They did an absolutely fabulous time. So I think it's very important that we do what we can to partner with our hospitals to keep them here for our residents and our families, because we're not going to grow as a city if we don't have health care.
Thank you, Sherry.
And Joe, to your point too, and to your point also, there have been hospitals in the last 2 years, I won't name them, it's been in the newspapers, who have gone bankrupt and they're closed.
Yes,
Period.
we're totally aware of that one, that's for sure.
And-
Joe?
And again, to reiterate, it's important that we shore up the financial condition of our hospitals. I truly believe that. And I appreciate you simplifying, at least for me, and I'm hoping to our citizens out there who's watching, a very complicated issue, healthcare, and how that impacts all of us, and how this is going to help shore up our hospitals in the long term, is going to make you more financially viable so that you're here serving the citizens of Goodyear. So I appreciate that, and that's probably the toughest part, is to take something complicating and simplify it for those that are watching us and staying with us, and I do appreciate that.
Well, you're
Thank
welcome. And by the way, I made a comment earlier about our desire. You talked about no hospital earlier in the 90s. Now we want to take the next step and do a trauma center here.
Yes, we understand that.
I mean, much, Joe, back to your financial question of what happened, you remember the state of Arizona was in a bit of a fiscal squeeze, and what got cut, $500 million a year, was health care.
Yes.
I mean, it just was. Fortunately, state law was passed allowing us to do this, thank God. So we expect to be here for a long, long time and keep growing.
Yeah, I expect you to.
Oh, yes, sir. And I'm only 39, so I will be around for a long time.
Well, I think some of the explanations have been excellent because it takes the politics out of it, and it brings the need. And that's the most difficult, I think, time frame we're in the United States, is everything becomes political. And so it's very hard to work on issues that are meaningful and save people's lives and improves your city in that way. So I look at this as care. I mean, true care for those that need it, and in a sense, not costing those people who are out there paying their insurance, you know, and doing that. And so I think this is a great program, and I'm not sure you're done with your presentation. So
One more comment. You should know that in all the thing, and I guess to both of you, and Sharon, who's been head of a chamber, what we are doing and did in Phoenix had the unanimous support of the Arizona Chamber of Commerce and Industry, and that represents the entire spectrum of the economy unanimously. That chamber never does anything unanimously, but it did it in this case because it meant something. It meant people with cancer weren't cut off in the middle of their chemotherapy.
are we finished with your presentation, or do you have some more to go on?
Well,
Yeah.
there's just, I think Reg did an excellent job of really covering this slide, and I just wanted to maybe walk through so that you would get a sense
Please go
of
ahead and finish
the
it, yes.
process, and then I'll turn it back over to Annette. But this slide is really just to give you a sense of all the different sort of agencies that we'll need to work with to get this done. And it may seem a little daunting when on a slide, but it's certainly something that has been done before, and all of those paths that already have been cleared for us will make that easier if we decide to go in this direction. So for the Goodyear City Council, the first 3 bullets that you see there are really shorter term actions. You know, there needs to be notice posted that there's consideration of the ordinance. There would be a 60-day period during which presumably there would be outreach, and certainly in Phoenix, the hospitals were very much involved in helping to get word out to the public and participating in hearings. And then also taking the ordinance to the Municipal Tax Code Commission. I'm sorry, yes.
I do want to chime in a little bit on that, so you are fully aware if you decide to move forward with this. The Municipal Tax Code Commission is scheduled to meet sometime in September. They don't have,
room.
yeah, they don't have a set schedule. So if you were to give us direction to post the notice, the 60-day notice tomorrow, we would need to take this to the Municipal Tax Code Commission before you had a chance to adopt it by ordinance.
Okay.
Because we don't know when they would be meeting again or if, and then that would really complicate things. So we wanted you to be fully aware of that and not to get out ahead of you, that this would need to be done at that time before you even have a chance. And you still have the option of voting on it still in October. It doesn't commit you to that, but
So what does this commit us, I mean, you want a yay or nay to go further? Is this what we're?
Tonight, this is a briefing session to make sure there's some general support for us investing
Okay.
staff time
All right.
in moving forward and drafting the ordinances, drafting the intergovernmental agreements, and working with our partners on this. So really this evening, absent
So you want to
concerns by
see a
council,
nodding of heads, essentially?
because we can't vote on anything this evening. We won't vote on the ordinance until the 60-day notice
Right.
period has elapsed. So if there's general support for council and staff investing our time to continue to work through the process, these are the steps we'll be taking before bringing the ordinance back to council.
And I have
Yes.
one more comment under bullet number 2 with the public outreach. Actually, that is something that West Valley Hospital and Tri-Advocates and all of that have volunteered to do public outreach, do meetings, hold those meetings, and answer those questions. So that is one thing that is not on our plates. They have stepped up to the plate and said they would handle that public outreach. We can do more in addition, but they'll hold public meetings and
Joe?
More for the attorney, what all you heard tonight as far as direction and the presentation to make sure some of those key points are all in there from an ordinance, do you have enough to work with the hospitals to come up with something?
You need for an
Yes, I
ordinance?
think we can certainly meet those deadlines, if that's the question. I mean, there certainly are several models of the ordinance, and they're all kind of, you can kind of see them morphing as they've worked through the various issues. So I don't think, from a legal perspective, we're going to have issues getting the ordinance together, but there's certainly you have a lot of homework to do with the federal and state agencies as well. So
Okay.
the first step is, if council is generally supportive of staff continuing to work on the project, then we'll work on posting the 60-day notice, and that likely will be as early as tomorrow, to get that clock running, to hit that 60-day point where we can actually come back to the council and have you formally consider the ordinance for approval.
Wally?
I'm assuming since Phoenix has done it and Mesa and the other cities have done it, we certainly could use what they've done as a sample, so we're not spending a lot of time on it. If they've got it all worked out and that sort of thing, because time is of the essence.
Oh, certainly.
And,
Certainly, we're not going to reinvent the wheel if we don't have to.
Good. I just want to make sure that we don't have to reinvent the wheel here. If they've got all of this already done, we ought to be able to just boilerplate it as well.
Tucson passed an ordinance last week, so that's
Perfect.
It's pretty.
you know,
Okay.
the newest one.
We haven't heard anything from Bill. I just want to make sure that you're there and you've heard all this, and if you have any questions.
I am. Thank you. I appreciate that. I have been listening, and I agree with everything that everyone has said. Obviously, a strong hospital in our community is a huge benefit to both our residents and from an economic development standpoint. So I'm fully in support of that. The only thing I'd like to throw out for consideration, I think, in addition to everything else we've already talked about, is kind of keeping track of the staff time and hours that we're putting into this so far, and throwing that into the administrative costs, because all of this effort is not, out there for. We're going to spend an awful lot of staff time to get this done. And there's a financial implication to that as well, and I'd like us to consider utilizing that as as part of the administrative costs as we look to move forward on this.
I think it's going to be addressed, Bill. If you're finished, do you have anything more?
No, I'm done. Thanks.
All right, great. We really appreciate, and we know how difficult it is to be on the phone and listen to a presentation, and this had a lot of information. So I think part of your question will be answered right now.
We did this with the city of Phoenix. It billed us. We paid.
Okay.
Point two, we are going to end up working for you now. And as I didn't say this earlier, I'm a principal of Vanguard Health Systems, a national company which owns Abrazo Healthcare, which in turn owns West Valley Hospital. All those resources are going to be at hand to help get this thing done.
Great.
So we now work for you,
That's great.
Brian.
So, you know, as the mayor, I have to tell you, when I first got the telephone call, I certainly was sympathetic and understanding, because it isn't so important to keep our emergency rooms and our hospitals open, but advance the hospitals, advance care. And it even will help you with the public. You know, there's always those people that enter the hospital and leave with a lot of complaints. And a lot of the time it's because there's not enough staff. Everybody's worked so many hours. And I think by being able to improve that system, that takes away some negativity that comes from hospitals, because we all experience that. And personally, as you well know, I've been a patient a couple times in that hospital. And they gave me quite good care, and when they couldn't give me what I needed, they referred me and took me to another hospital. And so I appreciate that personally, that I had such great care and such good advice. So now we're just going to look at each other and kind of get a nodding of heads. So I'm going to go around the table, and are we finished with the presentation? Because I don't want to stop you. If you've got one more, go for it.
No, I think that we have covered all the really important pieces, and the last slide was really just to reassure you
Why
that
don't you just go ahead and reassure us?
I will reassure you that you all really are the decision makers here, and nothing with the assessment, no matter what else we might pursue in the meantime, nothing will happen until you all vote yes or no on the ordinance. And with that, I just wanted to thank you for your time, and also say that certainly to the extent that I can be a resource based on having done this now in 2 other cities in Arizona, I look forward to working with you all and will be of whatever assistance I can be. And thank you for your time and coming in tonight.
And,
Yes.
and by the way, as far as I know, the only chief nursing officer of a hospital in the state of Arizona to wear a white uniform with a white cap is at West Valley Hospital, because I met her today and was astounded that the
Wonderful.
white caps are back.
Yeah, that is unusual. Thank you very much for that information. So what I'm going to do is just go around the table, and I'm looking at Councilwoman Holman, and you give me a nod, yay, nay. Do you think the staff should continue?
Absolutely.
Okay. Councilman Campbell.
I'm going to say yes, but I've never been a patient at West Valley, but I've been a volunteer there for many, many years, and I love that hospital. I was in the first volunteer class in the ER, and I do know from my personal experiences that West Valley gives the best professional care that's available to anyone that walks through their doors. And I am so grateful that you have recognized a stream to be reimbursed because of so many uninsured people who have come through our doors seeking care and have never been turned away. And I appreciate you doing that, because you're taking that burden off of me as a taxpayer and as an insured person. So I thank you for bringing that to the council's attention and to our city. And just know that our council, as well as all of our city, support you, and we're very happy that you're here. We want you to be successful, and we'll do everything we can to help you do that.
Thank you.
Thank you for those comments, Councilman Campbell. I'm going to go to Councilman Stipp, because he's on the phone. I don't want to forget him. And so, Bill, do you have anything to say? I can't see you nod, so I need to hear something verbal from you.
Well, I actually thought about coughing as an affirmative to that.
That works.
No, I won't go long because I'm on the phone, but just I think it's a good idea. I actually had the opportunity to reach out to a professional in this field outside of our region over the weekend when I received the packet, and was informed not only is this a good situation for West Valley Hospital. It will help stabilize them financially, or at least strengthen their position, and it is going on throughout the state. So it seems to be a good fit. In addition to the opportunity for us to fund the Medicaid expansion that was recently approved by the state, is my understanding as well. So this is it's a good project for us. So I'm happy to see it move forward.
We appreciate that, Bill, and also for your work of going on the outside and getting a confirmation on the program. And so we appreciate that time you've taken away from your job to do that. Councilman Pizzillo.
As I mentioned, anything that shores up the long-term financial viability of a hospital not only benefits the hospital, but benefits our citizens. So, need I say any more?
No, Councilman Loretano.
Yes, I support it. I already stated the reasons why. I think we've got some great medical care here, and I'd like to see us become regionally, and I think we need to grow the hospital.
Yes. Right. Well, I want to thank the council for all coming together on this, and I think we're all in the same boat. We want our hospital to be the best, and we want to stay here in Goodyear, and we want it to advance, and all the good things you've all said tonight, we're absolutely 100% in favor of. So if that it finishes the evening, we want to thank you for coming tonight. We really appreciate it. This was the one part of it that was lacking, was the information, and you certainly showed us tonight. We have all of the information to make our decision on. I'll turn it over right now to the city manager.
Yes, thank you, Mayor, members of the council. A couple of things. One is, and I just want to reiterate, thank you for coming in on your vacations. A very important topic that we talked about. And, thank you to your team, for Vanguard, Abrazo, for really making this, bringing this to our attention. So appreciate that. And I was on vacation, so I keep looking over Winnett, and Winnett really hurted the staff quite well. I say hurted, but involved legal, involved finance, involved several people. So I want to thank you personally for all your hard work behind the scenes while I got to enjoy my vacation. Last thing I would, just an invitation, and perhaps it's for staying home, but there's a lot going on at the hospital. A separate time because it's not part of this work session, but to get, if nothing else, a communication update in the fall as far as what's happening with Trauma Center and some of the plans that are going on at the hospital. I think that'd be very valuable for the council, for the public to hear. So when you're at that point, we would absolutely entertain you coming back before us on that issue.
I accept that invitation.
It's a deal.
Would you like to see some surgery, or?
The table is big enough. We can clear the table, and we could actually have it right here.
Yes. Well, with that, I think all business is taken. Yes.
We thank you, and you're thanking us. We're very grateful for you coming in. This is so terribly important, so please accept our robust appreciation.
Well, thank you. It's just nice to know it's a team effort.
Yes.
We all love this city, and we want the best for it and the citizens. So I think that we all came together. That's great. So with that.